6 years, we've worked to find a patient-focused, adult-appropriate approach to single-dose cardioplegia. A few disclosures. I'm on the Speaker's Bureau for Quest and occasionally act as a consultant. I have a small intellectual property interest. The last year and a half I've been off the grid adding mom to my resume, so this is my little guy. And it should probably be more of a disclosure and disclaimer than an icebreaker, and that mom brain is a very real thing, so if I say something a little backwards here today, ask me to clarify at the end. Little background on our program. The WellStar CT surgery program started in 2004 under the leadership of Dr. William Cooper. I joined him from the very first case, and we've had the pleasure of working together ever since. It's been a dynamic program. It's grown to over 1,000 cardiac procedures a year, inclusive of complex valve repairs, extensive aortic surgery, TAVR, VAD, and ECMO. Kennestone's cardiac program has been recognized by Joint Commission and has received several accolades over the past several years, most recently receiving C4 certification with comprehensive care. Several objectives here today. First, the KBC protocol, how it was developed and why. The methodology, what makes it work for adults, and why communication is key. We're going to give you a surgeon's perspective and let you hear from Dr. Cooper as to the need for standardization, and lastly, data, because without it, everything else is just an opinion. And the biggest objective of all is to get everyone to the cocktail hour on time. Cardioplegia controversy. In 1979, Buckberg predicted an end to it concerning which solution we should use, but here we are in 2019 still talking about it, and it's as much of a controversy as ever. So hopefully you won't walk away from this thinking it was yet just another cardioplegia talk, but there'll be something that piques your interest and makes you go back and look at your own program a little differently. So in 2013, Dr. Cooper came to my colleague and I and said, let's try single dosing. We had heard an area hospital was doing it for some adults. It was kind of becoming a little bit of chatter across the country, so let's give it a shot. But we were an institution of long-standing Quest microplegia users. Many of us had had the luxury of using the Quest system for over a decade. We embraced the system's ease of use and the many well-developed safety features, but most importantly, we embraced the unmatched benefits of all-blood cardioplegia. So we said, okay, let's try single dosing, but let's do it without the crystalloid. So we tried traditional Del Nido in its true sense one time, and we looked to the solution for some guidelines. What did we know about it? It was originally developed in the 90s for pediatric use. It was a pediatric solution, 1 part blood to 4 parts crystalloid, utilized potassium as the arrest agent, sodium bicarb as the buffer, lidocaine, giving it a sustained arrest, magnesium sulfate, and mannitol, lidocaine being the key superstar. Our goal then was to eliminate the crystalloid, and in doing so, we no longer needed the sodium bicarb as a buffer. The result was a long arresting solution that provides the convenience of an extended arrest, but utilizes the patient's own blood. Is this a big deal? We think so. When it came to single-dose cardioplegia, we felt we had several questions to first answer. Is it appropriate for all cases? We were an adult practice, but yet Del Nido was designed for the pediatric heart. Can we customize the method? We're a center of everything from cabbages to complex mini mitrals and extensive aortic surgery. How do we accommodate all those patients? How can we standardize but individualize at the same time? We know there are differences between the pediatric and the adult heart. Their primary energy substrate, one uses glucose, one uses fatty acids. Adults present with hypertension, ventricular hypertrophy, coronary artery disease, all these things inhibiting uniform distribution. So should we be treating these two the same? Arguably no. Why would we force the adult heart to fit into a pediatric protocol? Protecting life with science. This is a powerful statement that Quest has used as a slogan for their advertisement for their MPS II. The Quest myocardial protection system truly does accommodate individual patient needs at the touch of a button. I'm sure many of you who are Quest users may agree with me that the MPS is quite possibly one of the greatest advancement in perfusion technology in the last 20 years. In the realm of perfusion, much else has remained the same. However, this out-of-box thinking gave us the tool to accommodate each and every patient. In my opinion, after a user for almost 16 years now, the MPS should be the gold standard for any institution when it comes to cardioplegia delivery. Notice how the Quest has provided the maximum amount of functionality at the fingertips of the user. With simple setting adjustments, one can give any ratio they desire, from all crystalloid to all blood, with independent control of the drug portion. Why were we so insistent excuse me, on maintaining our setting at all blood? This is because we all embrace the benefits of blood cardioplegia. First, with decreased systemic hemodilution, improved glucose management, reduced myocardial edema, and it was naturally physiologically buffered. So we could have ran crystalloid delnito through our MPS device, but why would we? With this type of technology, why would we limit each patient to a pre-mixed bag? Why would we revert back to crystalloid if we did not have to? This is a powerful slide that Quest displays. It compares the myocardium of an all-blood microplegia to 4-to-1 blood cardioplegia. Note the increased interstitial edema with just one part crystalloid. Now imagine if we compared a microplegia slice to that of a 1-to-4 blood to crystalloid. Let me be more specific. What if we compared all blood microplegia to delnito in its true sense with 1-to-4 crystalloid? What increased interstitial edema would we see? We know that myocardial edema decreases contractility, so why would we add crystalloid if we did not need to? Let me ask it another way. Why would I give a full liter of this when I could give 50 mLs or less from a syringe and get the same desired sustained arrest? In a culture with blood conservation at the forefront, we were always challenged to do what we could to minimize transfusions. So here we are faced with the trend of single-dose cardioplegia in our all-adult world. However, our goal quickly became one greater than just that of the sustained arrest in one single dose. We sought to incorporate the patient's own blood with a method that improved efficiency and heightened standardization in our practice. The KBC Method. So why a new name? We knew the minute we made any variation to the delnito protocol or formula, including the crystalloid component, that it ceased to be delnito. We also considered it imperative to differentiate our adult-specific method from that of Dr. Delnito's. The KBC composition still utilizes potassium as the key arrest agent, lidocaine, magnesium, and mannitol, with the similar properties they lend to delnito, with lidocaine as a sodium channel blocker, giving it that increased refractory period and thereby leading to that sustained arrest that everyone looks for. The key concept here, though, is the all-blood carrier. So how does this get to us? So our pharmacy has been very accommodating, and they've worked with us a great deal. So they prepare this for us in a 60 cc syringe, and we keep it in our Pyxis or Omnicell for up to 7 days under refrigeration. The cassette pouches of the MPS are key and unique to our method. These give the user full control of what drug is added, how much, and when. No longer are you tied to a pre-mixed bag of cardioplegia. We manually load the additive pouch with the syringe from pharmacy and the arrest pouch with concentrated potassium. Finding the formula was quite honestly the easy part. The true challenge was in adapting the method. In order to apply this formula to adults, we had to challenge ourselves to think differently. We had to change the way we think about cardioplegia, specifically in regards to dosing. We had to abandon the one-size-fits-all mentality that had accompanied single dosing in the past. We were used to frequent dosing with our old cardioplegia every 20 minutes, Now we were giving one dose and sitting and being asked to wait, but at the same time, know that we were protecting the heart. We wanted a method that was easy to follow. We wanted something that gave our team direction, and so we came up with this ever-evolving three-part strategy. First is the induction dose, a dosing assessment, and lastly, a warm reanimation. The induction dose is weight-based at 15 mLs per kilo. We deliver a minimum of 1 liter and a maximum dose of 1,500 mLs, all delivered cold. The additive and arrest settings are on the MPS at 21 and 21. So 1 liter dose delivers approximately 2.5 grams of mannitol, 1.6 grams mag sulfate, 100 milligrams of lidocaine, and 21 milliequivalents of potassium chloride. The second part of the method is the dosing assessment. The dosing assessment is our guide. We do an assessment every 60 minutes or with any activity. If we want to give a redose, we evaluate 2 key things. First, what is the current potassium level? And what's the estimated remaining arrest time desired? Because this is a long arresting solution, giving a full dose is assumed to re-arrest the heart for upwards of 60 minutes, and it does just that. So this is where the flexibility of the MPS becomes integral. The reanimation dose is something we firmly believe in. We give 400 mLs warm with no potassium and a variable additive setting. If we've allowed 1 hour or more to pass since the induction dose, we give a full setting with the additive at 21 and the potassium at 0. If it's been less than 30 minutes since our last dose of cardioplegia, we give no additive and just run warm blood. If it's anywhere in between, the Quest gives us the flexibility to give that additive at 10 and the potassium at 0. So this middle ground dose is probably where we are, I would say, 75% of the time. The full dose in the warm setting gives us 40 milligrams of lidocaine, 1 gram of mannitol, 0.6 grams of magnesium sulfate. So we were asked all the time, well, what do you do for coronaries? What do you do for this? What do you do for that? So we've come up with a few procedure-specific adaptations. Now, in our institution, most of our surgeons were Emory trained, so we were a big off-pump coronary artery bypass facility. But occasionally we do cross-clamp a cabbage, and when we do the usual induction dose, followed by cold blood down the vein grafts, most often to measure flow, and then still remain with the reanimation dose. Now, for the instances where we're running blood down those vein grafts and we've exceeded 200 mils, then we turn the additive setting back on to 10. And this is primarily to prevent complete washout of any lidocaine that was keeping the heart sustained in that arrest at that time. What do we do for shorter cross-clamp times? If it's under 45 minutes, yet again, the usual induction dose. For subsequent doses, really you only redose when there's activity. And this is where I'll speak a little bit more about comfort dosing, but you really want to minimize the amount of cardioplegia you give close to that cross-clamp removal. If you do have to redose due to activity here, we're giving it at a low setting. For minimally invasive mitrals in particular, usual induction dose, but drainage is key. And everyone always asks about, well, what about the right heart and right heart failure? And minimally invasive mitrals has been the really tricky caveat with this. And what we've found is that the key is making sure that right side is empty, and the surgeon can't see that. So we have to be their eyes for them here. Subsequent doses on these cases, we can redose as often as 20 minutes, and this is why the MPS is so key. We have to be able to adjust that additive setting. You can't continue to redose and redose and redose lidocaine at a high setting and think the cross-clamp will come off and spontaneously the heart start beating. So the big tendency when you're transitioning from traditional cardioplegia towards a single dose or extended arresting strategy is where our comfort level lies. And so we've coined this as comfort dosing. And basically, it's when there's no activity, but you're nervous because it's been 65 minutes and you're not taught that that's okay, and you just give a dose to give a dose. And this actually, in our practice, has been counterintuitive and been the one thing that prevents that heart from really spontaneously taking off when the clamp comes off. So if you're asked to give a comfort dose, we're always going back through our dosing assessment. Is there activity? What's the potassium level? How much longer does the clamp have till it comes off? So it really takes you out of your comfort zone, but yet again, outside of our comfort zone is where the magic happens. Key points in this, probably the most important single thing you could take away is the importance of a very good initial arrest. And what's the best way to achieve that is with a quick ramp up on the NPS to your target delivery pressure. We emphasized to our entire team that that initial delivery pressure is the key piece in all of this. Most of the time, we're able to arrest people with their induction dose, even with aortic insufficiency. If your induction dose does not achieve the desired arrest, then you look at how you're delivering it. Do you need ostial? Do you need retrograde? And you convert at that time. The third thing is minimizing the amount of additive given within an hour of the cross clamp coming off. Adequate drainage, especially in the instance of minimally invasive cases. And communication is key. Communication, by utilizing our dosing assessment, helps provide accountability to our patients, it guides our individual dosing, and it creates dialogue and opens communication between us and the surgeon. Before perfusion kind of sat behind the pump and we all tied to the same protocol, this has really created that interaction. We have information they need, they have information we need. So this is from AORN, and occasionally I feel like this is what our OR looks like. The music blaring for sure over perfusion's head. And we pump behind the surgeon's back, so it's occasionally difficult to hear what they're saying. It's difficult for them to hear us. Many times they probably wish they did not hear me. But as perfusionists, it's part of our job to ask the right questions and pass along the right information. So where are we in the procedure? We need to verify where we're flowing on our delivery. Am I going down both ostia, the right, the left? To remember when it comes to redosing, which side have we protected? Need to confirm adequate distribution and arrest. They have information that they're looking for from us. Have we seen any activity? What's the patient's last potassium level? How long has it been since the last dose? For minimally invasive cases, we note changes in volume status, as quite often we're more aware of those volume shifts than they might be. So now I want to let you hear from Dr. Cooper and kind of give you the surgeon's perspective on all this.
Good afternoon. How are you all? Everybody good? All right. Well, great. Thanks. I'm going to spend just a few minutes in touching on some things that Catherine talked about, and then give you a little bit of perspective from a surgeon on how we developed this and where we are today. I'm not a big data kind of digging down into propensity matching, and we cross-matched and checked and did all these other things. So I'm not going to get into that, okay? I'm going to show you some of our data, but I will get into details specifically about how we got here and how you can incorporate this into your practices. And before, I always sort of get ahead of myself, I just want to say this. Steve Jobs also said that you can't steal second base and keep your foot on first. You got to go for it. And so that was a little bit of what we did here with KBC. I also want to say that I've had the opportunity in my career in cardiac surgery to work with some of the finest people that are in this business of doing heart surgery. I trained at Emory, and we had some of the greatest staff that you could ever imagine from a heart surgery perspective. from a perfusion perspective. And certainly now with Catherine and Candace Kalin, I'm still being supported and held up by their intellect and accountability. But if you really think about it, cardioplegia is one of the most important things that a heart surgeon does. Think about that. I mean, this is kind of spiritual. It's one of the most important things that you all do. Go jump off a cliff and come back. Anybody ever done that without a parachute? Without a springboard or something, sitting at the bottom of the gorge waiting to kick you back up to the top? No. Stop somebody's heart and bring them back to life. You guys do that every single day. And when I started thinking about this and how important that is, it really, really I started to dig down into this really deep when I was a fellow and did a lot of research in Jake Venjo-Hansen's lab, as you all know, who worked with Dr. Buckberg, is one of the pioneers in cardioplegia. But this is one of the most important things we do. And yet, I'll show you some data later that it's probably one of the most haphazard things that we still do in cardiovascular medicine. So we'll talk a little bit about the history. Since the pioneering work of developing the heart-lung machine by Gibbon in the 50s, people have been looking for that ideal solution. Since that time, early techniques that were widely used to arrest or protect the heart were based on single or sometimes even some combined modalities. Whereas these modalities alone or in combination have survived up to the present day in some institutions. During the 1970s, they were mostly supplemented with or replaced by arresting the heart with, quote, cardioplegia, based on chemical means. Those people like Blees and Brett Schneider in 75, and Follett and Gay and Ebert and others. But essentially, if you look back, hypothermia sort of started it all with topical cooling with Bigelow, global ischemia or continuous or intermittent aortic occlusion, Dr. Cooley. I would wonder what some of those patients' brains were like after you cross-clamped the aorta several times. And then Kay introduced aortic root or intracoronary perfusion with blood. And of course, Sinning and others looking at using fibrillation. The chemical arrest through rapid induction of the arrest and diastole is really what we're after. And then we want to be able to sort of stop the heart, and then we want to be able to maintain it in that sort of suspended, animated state by slowing the rate of cellular reactions, thereby delaying energy decay, ischemia, and all the things that go along with that. And then, of course, you want to add nutrients into the mix to further protect and therefore allow you to reverse this process at the end. There's some really important people, and I take absolutely nothing away from all of these people, including, and I would throw on this list, my mentor and former boss, Robert Guyton, who, Ty, you remember Robert came up with the oxygenated, cardioplegia thing bubbling in the operating room. The first time I came in there when I was a young whippersnapper with oxygen floating through this thing standing by the side of the bed. But I would put him on the list of people here who did pioneering work, and then subsequently we were able to steal Jake Venjo-Hansen and bring him to Emory to help us further develop some of the techniques. And then we moved into 2000, and I bring up Jake's name because, again, he was another one of my mentors in looking at the effect of pre- and post-conditioning. How can we modify these conditions to the extent that we can before and after we induce arrest? And then along came the emergence of the minimally invasive procedures, many mitrals, many aortics. Simultaneously, there's been a lot of talk over the years, as you all know, with the big study that was published in the New England Journal of Medicine that talked about restrictive blood management and not transfusing to a crit of 28 or 30. Of course, we've gone through the cycle of glucose management, and then, of course, also continuing to look at the systemic and neurocognitive effects of what we do on the body. And so here's kind of what we're trying to do. Rapidly induce, easy reversal, relax the heart so that we can move it around, try to do it in a timely fashion, try to do it with as little blood loss as possible, and then wake the thing back up and have it tick on its own and go on to the next one. On top of all of these things that are happening within these changes within in sort of the study, if you will, of cardioplegia, there's also on top of that now the healthcare system challenges to become better and more efficient at what we do in terms of quality, cost, and access. How can we standardize and reduce variability? How can we improve on the patient experience and the outcome of those patients? And how can we be responsible stewards for the cost? We did some early cost analysis on KBC when we first started, and we looked at, again, this is just very, very raw, sort of unadjusted, unreally teased out data, but this is what we saw. And this is what our hospital cost was per patient in patients who had a retrograde catheter versus who didn't get a retrograde catheter with our KBC technique. And then we looked at the patient costs. Of course, we know those things are passed on to the system through whatever payor may be responsible for that. So I think it's important, and one of the things that I think I brought to this is trying to get all of our surgeons on the same page, doing the same thing, and trying to be as consistent as we can in terms of how we execute and communicate with our perfusionists. If you imagine our patient population is going to come with all types of variables. We know they're diabetic, they're high blood pressure, and all the comorbidities along with that. They may be a little overweight, they may be a little thin, they may have a not so normal ejection fraction, et cetera, et cetera, et cetera. So, and then you throw into that mix something like this, and this is a slide from CAPS. I think we took this offline a few years ago when we started down this road of trying to standardize and develop KBC. I think CAPS was offering 900 different cardioplegia solutions. I think they're down now to 29. I think they sent out a circular a couple years ago and said, you know, this is kind of, some of these things have been sitting on our shelf collecting dust. Why are we doing this? And then we also participated in a survey of 3-star programs, STS 3-star rated programs, which, as you all know, is a top-rated program by Kira Grathwohl, who is a perfusionist. I think she was at in Detroit at that time, and basically just asked, what is your cardioplegia technique? What are your surgeons doing? And of course, at that time, we were not using KBC. We were doing the standard, old school, I call it, Emory blood cardioplegia, using, of course, at this point, we'd upgraded to the Quest system. But then even within institutions, what you found when you looked at this data is you would have a single institution that had 3 surgeons who literally had 3 or 4 different ways of administering cardioplegia depending upon what the patient presented to them. I was astounded, because I remember coming back to Catherine and Candace and saying, I don't know how you guys would operate in this environment. I mean, this has got to be absolutely overwhelming. And indeed, it was. So we came up with, well, I challenged, and I'll add a little bit more to what Catherine has already said. I was doing and started doing minimally invasive mitral valves at Kennestone Hospital simultaneously with what my partners were doing on the Emory campus. And I remember that one of our biggest challenges, and one of the things I thought was going to be difficult for us to sustain this, was our cardioplegia technique. Having to, as you know, with the minimally invasives, the heart's pulled up, the surgeon has a really myopic kind of a view. You're looking down a little tunnel. You can't really see all the things that are going on around the heart. So that was the thing that really, I said, you know, can you all come up with something I can just give one dose of blood cardioplegia? Why don't we look at this Nido solution? And Catherine's right. I did it once. And the crits on pump were 15, 16. They're, you know, do you want to transfuse or whatever? And I'm like, you might as well transfuse. And then we come off pump, and we, despite all of the management of fluid volume on pump, patient's crit is still 21. We're giving blood. We end up having to give products to deal with coagulopathy in a patient who I did an incision that's this big. I mean, does that really make sense? So that means we're putting something into this system that probably is not necessary. And so I challenged them to say, what do you think if we just put blood took out all this crystalloid and just put blood in it. And so we went through several iterations, and KBC is what we finally came up with. We can talk about this later, but I will say one thing while it's top of mind for me. The minimally invasive is not only about drainage, it's also about temperature management. And so if you got to remember when you talk to your surgeons about minimally invasive, particularly I think through the chest with a mitral patient, that patient's heart is still being insulated by a nice warm body. And so one of the things that I do for that, although we don't do any temperature probes in the myocardium or any of that stuff, one of the things I will do, however, is take a slush syringe and squirt slushed ice down into the ventricle as I'm working on that mitral valve, into the ventricle as well as around the pericardium. So I think temperature management may be one of the things that is perhaps overlooked with these minimally invasive patients and some of them that develop right heart failure. I think it's also important to look at the degree of aortic insufficiency in those cases and how well that first antegrade dose is going to work. And then I think coronary anatomy is very important. Patients with non-dominant right coronary systems, how are you going to ensure right ventricular protection under those circumstances? So a lot of little things here to think about when you want to use this technique. And so it's temperature, it's distribution, all the things that we worry about with traditional cardioplegia. And then how can we, get beyond the knee-jerk, just give cardioplegia because it's 20 minutes? Does anybody know any data that really supports that, besides maybe Buckberg's dog data from 1980? I would like to know because I've looked for it. There's no real good data to support giving anything every 20 minutes. And so we sort of started to challenge conventional wisdom and thinking. And just so you know, one of my partners is actually given one dose of cardioplegia in a patient, 2.5 hours, no additional cardioplegia, nothing. Person was underwent, I think it was an aortic dissection, gave a single dose through the coronaries directly. After he got to circ arrest temperature, gave nothing else. And the patient came off pump, no problem, was extubated the next morning, went home in 5 or 6 days. Now, I would never do that, and I have a different technique for aortic dissections, but those are the kinds of things that we see. And again, these are just anecdotes, but I think the important thing to understand here is that this is an operation, this is a technique that we think, without having that scientific benchtop data, may actually be superior. It may meet a lot of goals that we have for our cardiac patients. Some of the challenges, as I talked about, minimally invasive, ablations in terms of how do we deal with this in patients who are going to add these types of procedures to the operation. Lidocaine dosing, we've talked about or heard about the lidocaine allergy. I don't know if that really exists. In now over 2,300 patients, we had one patient that I think we said had an allergy, and we didn't give we went ahead and gave the lidocaine anyway because the pharmacy would have to completely change how they mix this for us. So it's a desired method for us for all patients. Open, first time, redos, mini thoracotomy, left thoracotomies, partial sternotomy. It doesn't matter. We give all of our patients this valve replacements and aortic work, all of the above. One of the caveats I will say, and one of the biggest things that I've seen with this technique early on, which we don't see very much anymore, is we would run really high potassiums just randomly. It didn't really seem to make a lot of sense. So we include potassium, or the potassium level, in our decision to redose. The other thing is, in patients who have significant aortic insufficiency, I will, and some of my partners will, give our induction dose through a retrograde cannula with a cross-clamped and vented aorta. And you do that until the heart stops beating. We go ahead and put topical ice on top of the heart, and then once you open, if you happen to open the aorta, you can give it an additional dose directly into, if you're concerned about the right or even the left, you can give an additional dose directly into the coronary ostia. So those are some things that we think about in dissections. retrograde, circle rest, under circle. When you go to circle rest, you give the retrograde induction dose, and then decide after you've done your repair whether or not you need to give an additional antegrade dose or just move on to the rewarm and the reanimation dose. All right. In terms of back to the types of patients, age doesn't really matter. I'm just making the point here that we don't really discriminate in that regard. We do discriminate based on some patient factors that I just mentioned. In terms of the size or any of those things, we stick to the 1,000 to 1,500 max. And if you look at bypass times, if you were to throw this up here, and I didn't, and cross clamp times, I didn't do that for this, but this would be in all of these categories would be very similar, if not in some cases better than STS data and averages. Length of stay, all of those things. If you look at all of our patients in sort of conglomerate in-hospital mortality from 2016, we had a little blip there in 17, but essentially is on par with STS. This is our observed in-hospital, and then operative mortality, all patients, all comers. This is risk-adjusted for isolated AVRs. We had none of those in 2018. Again, these are small numbers. As you know, a lot of these patients are going to have combined procedures, renal failure, deep sternal wound infections, as well as stroke. So where we are today, we've done almost at 6 years now. That was 6 years in terms of using this technique. Will be June of 2000, is that right, 2013, 2019? 2,300 patients, and we think we've got a long way to go. What are we missing? We know we're missing the big academic data, and we're going to work on some ways to try to get that. But when you're in a really fast-paced, high-volume, tertiary care, non-academic setting, it's hard to get the resources to have somebody come and spend literally probably a year teasing through all of this data. But for right now, for us, we think it's a superior technique. We're going to prove it. And we think it's a technique that will support all of the types of challenges that we're presented with as cardiac surgeons. Last comment, we don't do a lot of, most of this KBC data is in cross-clamped valves and other types of complex procedures. We don't do many cross-clamped bypass cases. I think in 2018, out of the 150 or so that I did, I didn't cross-clamp anybody in 2018. As a matter of fact, I think in 17 I cross-clamped 1 or 2 that were ischemic from the cath lab. We do either off-pump or on-pump beating, empty beating bypass. So very few or very little of what our experience entails is cabbage. One other point, this year I went to the STS. There were 2 papers, only 2 papers on the entire program talking about cardioplegia. Now, contrast to maybe 5, 10 years ago certainly 10 years ago, when you'd have 10 or 15 papers on the program talking about cardioplegia. Both of those papers were Del Nido versus blood cardioplegia. One looked at 863 or so propensity matched patients, really no big differences. One was a smaller study, cabbage only, and really some small differences in, I think, wound infections and dysrhythmias, but not major differences in terms of the major outcomes that are MACE-type outcomes that we look for. So those are my comments. I'll stop right there, and I think Catherine and I both will take any questions if you have them. Thank you very much.